Welcome to our webinar. Welcome to our webinar, Clinical Practice Guidelines for Physical Therapy Management of Older Adults with Hip Fracture. My name is Tom Herring. I am a physical therapist practicing in Phoenix, Arizona. This clinical practice guideline was developed in collaboration with the Academy of Orthopedic Physical Therapy and the Academy of Geriatric Physical Therapy of the American Physical Therapy Association. This guideline has been published in the February issue of the Journal of Orthopedic and Sports Physical Therapy. This webinar is divided into 6 short presentations: a brief introduction, 3 recordings covering interventions, and 2 recordings addressing outcome measures recommendations. The development of the guideline began in 2014 with the selection of a team of expert authors and research assistants. The guideline represents a systematic review of literature, gathering evidence from critical appraisal of published systematic reviews and studies through June 2020. Stakeholder input on the final form of the guideline included physician involvement in development of the manuscript, review by AOPT and AGPT editors, review by international experts, consumers, patient representatives, payers, and external stakeholders. And finally, the manuscript was open for public comment on the web. The guideline addresses fragility fractures of the hip. Over 90% of all hip fractures in people aged 65 years and older result from ground level falls. Fractures from these low energy, generally ground level falls are called fragility fractures. Our population included a global representation of older adults, 65 years of age and older, with low energy fractures of the proximal femur. Excluded were studies of high energy trauma, pathological fractures, fractures of the acetabulum, and those with fragility fractures that were treated non-surgically. Periprosthetic hip fractures and hip fractures resulting from failed prior fixation were not considered. Hip fracture places a large strain on the healthcare system. It represents a medical emergency utilizing many health services, from onset to recovery, not limited to acute care hospitals, inpatient rehabilitation, skilled nursing facilities, home health care, and outpatient services. Appropriate treatment requires the skills of surgeons, anesthesiologists, geriatricians, endocrinologists, physical and occupational therapists, nurses, nutritionists, social services, and pain management. Literature review revealed over a dozen risk factors for hip fracture, with older age, reduced bone mineral density, low BMI, and geographical factors to be some of the most significant. Fall risk factors are closely correlated to risk factors for hip fracture. A ground level fall is more than sufficient to produce a fragility hip fracture. Hip fractures are classified as intracapsular or extracapsular. Generally speaking, extracapsular fractures, either intertrochanteric or subtrochanteric, reflect poorer overall health status. Hip fractures may be displaced or non-displaced, and displaced hip fractures are more likely to be unstable. Surgical advances and devices allow for early mobilization of the patient and improved outcomes, as we will see in a moment. Goals of surgery are fracture reduction, alignment, stabilization, and compression of fracture surfaces while avoiding reoperation avascular necrosis, infection, and other complications. Percutaneous cannulated screws provide for quick stabilization and lower surgical risk, although more significant stabilization may be required. Femoral neck fractures can be treated with hemiarthroplasty or total hip arthroplasty. Hemiarthroplasty may have lower dislocation risk, but can be more painful in the active individual. Sliding hip screws, aka compression hip screw, and cephalomedullary nails are widely used to treat intertrochanteric and subtrochanteric fractures. Intramedullary device has a lower failure rate and is less invasive compared with sliding hip screw. Interesting to note that minimally displaced valgus impacted femoral neck fractures may have intrinsic stability and be satisfactorily treated with cannulated screw fixation. Hemiarthroplasty may have lower dislocation risk, but can be more painful over time in an active individual. Recent evidence indicates that traditional hip precautions after total hip arthroplasty or hemiarthroplasty may not reduce dislocation rate. We believe that post-operative precautions are prudently based on surgeon preference and individual factors. Regarding surgical approach, after hip arthroplasty, posterior approach carries higher dislocation rate and higher rate of venous thrombosis versus anterior approach. Increased operative time, blood loss, and rate of infection has been documented with the anterior approach compared to posterior. Variations of the lateral approach have demonstrated lower dislocation rates compared to posterior. Again, we see that hip arthroplasty compared with cannulated screws has lower reoperation rate and lower postoperative pain scores. IM nailing of intertrochanteric fracture is associated with improved postoperative mobility. Subtrochanteric fracture has a lower failure rate with long gamma nail versus sliding hip screw. An extensive review of literature revealed over 40 risk factors affecting adverse outcomes after hip surgery. The most significant of these were increasing age, lower pre-fracture functional mobility, comorbidity, and cognitive impairment. These factors were generally associated with higher mortality and morbidity, poorer functional outcomes, and increased incidence of complications post-operatively. Overwhelming evidence supported weight bearing as tolerated as early as possible after surgery, preferably within 24 hours, to mitigate the increased risks of mortality and morbidity. With advances in surgical stabilization of hip fractures and based on a low incidence of adverse events and complications resulting from early weight bearing and early mobilization, we can safely provide interventions that optimize functional outcomes. In conclusion, on this slide, we can identify the early postoperative course of care that provides the older adult with hip fracture the very best opportunity for recovery. No restriction on immediate postoperative weight bearing, starting PT with ambulation less than 24 hours postoperative, and increased frequency of PT during the first 72 hours. In the next presentations, you'll be learning about interventions and outcomes recommendations across the spectrum of settings. Thank you for your time.